Hello and welcome to all of you. I wish and I hope you're all in great health and taking care of yourself. Today we are going to discuss about yet another important topic, but it's in neonatology. So that is neonatal jaundice or neonatal hyperbilirubinemia. Now, we come across neonatal hyperbilirubinemia day in and day out, and therefore the various causes and what we have to do in each case, we need to know thoroughly. So let us study neonatal jaundice. So coming to neonatal jaundice, what is neonatal jaundice? So neonatal hyperbilirubinemia, it refers to an excessive level of accumulated unconjugated bilirubin in the blood and is characterized by jaundice, that is a yellowish discoloration of the skin, sclera, mucous membranes, and nails. Now, we all know that there are two types of bilirubin, that is unconjugated bilirubin or the indirect bilirubin, and conjugated bilirubin or direct bilirubin. Now, the main cause of neonatal jaundice is unconjugated hyperbilirubinemia. So this picture shows a healthy baby who is pink and nice, whereas the right side is a baby with severe jaundice with the yellowish jaundice hue. Now coming to neonatal jaundice proper, in newborns, jaundice occurs if the unconjugated bilirubin level is more than 5 mg per deciliter, whereas in adults, jaundice appears when the bilirubin level is more than 2 mg per deciliter. It usually occurs in 60% of term and 80% of preterm neonates. Since the liver is quite premature in the premature neonate, it is most commonly seen in premature neonates. So 80% of preterm neonates, or mostly the preterm neonates, usually have neonatal jaundice. However, significant jaundice occurs in 6% of the term babies, and 6 to 10% require phototherapy or other therapeutic options. So now coming to the mechanism of bilirubin metabolism in our body. So hemoglobin or HB comprises of two parts, that is globin, which is the protein, and heme. Now 1 gram of hemoglobin gives rise to 34 mg bilirubin. Now in our body, basically bilirubin is a water non-soluble, and it's a non-polar product or a non-polar molecule. So this bilirubin has to be transported in the blood. So bilirubin combines with albumin, and this combination of albumin and bilirubin makes it the unconjugated bilirubin. So this unconjugated bilirubin is then transported to the liver. In the liver, it has to be taken up by the hepatocytes. But at this step, that is where the bilirubin has to be taken up by the hepatocytes, something called as a ligandin receptor comes to play. And this receptor is extremely important for the uptake of the bilirubin into the hepatocytes. Now, once the bilirubin is taken up by the hepatocytes, it will undergo the process of conjugation. And with conjugation, it gets converted into bilirubin monoglucuronides and diglucuronides. Now, this key process or key step of conjugation is carried out by the enzyme UGT, that is uridyl diphosphoglucuronosyl transferase. And this is the key enzyme for conjugation of the unconjugated bilirubin into bilirubin mono and diglucuronides. So once the step of conjugation occurs, this conjugated bilirubin is then taken up by the intestinal cells. And in the intestine, these conjugated bilirubin is acted upon by the intestinal bacteria to convert into stercobilin so that it can be excreted along with the feces. And some of the conjugated bilirubin at this point is diverted and is acted upon by beta glucuronidase. And this enzyme converts conjugated bilirubin again back to unconjugated bilirubin. And the unconjugated bilirubin is then taken up again by the liver. So this process of deconjugation of the bilirubin is known as enterohepatic metabolism. Now, a few points that I would like to add over here, that is in case of our neonates, the intestinal motility or the gut motility is quite low in the beginning, as well as these bacteria have also not developed into their full capacity. As a result of which, the unconjugate and also enterohepatic circulation also increases in case of neonates. So as a result of which, the bilirubin excretion becomes slow and unconjugated bilirubin piles up and there is unconjugated hyperbilirubinemia. Now, when the baby is on the mother's side in our on the beds, and we are on our rounds, then how do we just look at the baby and without doing any blood investigation, just with or doing any transcutaneous bilirubin, how do we say that the baby has got jaundice or no? So for this clinical reason, we have got something known as Kramer's staging. So this is the modified Kramer scale, according to which the baby's body is divided into 5 parts. Okay. And based on which part has developed jaundice, we can roughly associate that with a particular bilirubin level in the body. So basically, if the face has jaundice, then level of bilirubin is around up to 4 to 6 milligram per deciliter. If it is reached up to the chest or upper abdomen, then it is around 8 to 10 mg per deciliter. Whereas if it has come into the lower abdomen or thighs, then it is around 12 to 14 mg per deciliter. And if it is in the arms or lower legs, it is 15 to 18 mg per deciliter. But if the palms and soles are involved, then it is around 15 to 20 mg per deciliter. Now, roughly our jaundice is divided into 2 types, that is physiological jaundice and pathological jaundice. So first, let us have a look at physiological jaundice. So coming to the characteristics, now the timing, that is physiological jaundice appears after 24 to 72 hours. This is the hallmark. If a jaundice appears less than 24 hours, then it is pathological jaundice. So physiological jaundice always appears after 24 to 72 hours. The maximum intensity is usually by the 3rd to 5th day in case of term and 7th day in preterm. So physiological jaundice itself appears later in the preterm babies, and it can stay up from 14 to 21 days in case of preterm neonates. The serum level is less than 50 mg per deciliter. However, in certain cases, it can also go up to 18 or 20 mg per deciliter. And physiological jaundice subsides by 14 days. It's not clinically detectable after 14 days. And it also disappears without any treatment usually. However, in certain cases where around 18 to 20 mg per deciliter it reaches, phototherapy might be required. And once a baby has developed jaundice, we have to continuously monitor the baby in order to watch for worsening jaundice. So why does physiological jaundice develop? Basically, we have gone through this entire pathway of bilirubin metabolism, and it is those various steps which, if hampered, will lead to unconjugated hyperbilirubinemia. So basically, first of all, in case of neonates, there is a sudden and increased rise in the RBC destruction, as a result of which excessive bilirubin load. Also, the liver has not reached its complete maturity, and therefore excessive breakdown of the RBCs is a lot of bilirubin load for an immature liver to conjugate. Also, the RBCs in case of neonates or preterm is going to be destroyed in 90 days as compared to the adult RBCs, which are going to be destroyed in 120 days. As a result of which, all of these 3 factors will lead to increased bilirubin load and hence unconjugated hyperbilirubinemia. Then there could be a defective uptake from plasma. Suppose there has been some genetic predisposition, as a result of which the liganded receptor is damaged. Then there will be defective uptake from plasma, so no conjugation. Also, there could be a similar genetic deformity in our UGT enzyme, as a result of which there will be defective conjugation. Next, if there is decreased gut motility, and also if there is a decreased amount of bacteria, then there will be a less production into stercobilin, and hence there will be decreased excretion. Also, if beta-glucuronidase activity is higher and there is increased enterohepatic circulation, all of these are going to lead to a risen level of unconjugated bilirubin in the body, and therefore neonatal jaundice. Now coming to pathological jaundice. So pathological jaundice, the onset of jaundice will occur before 24 hours of age. This is the hallmark for this. An elevation of total bilirubin that requires phototherapy. So basically, one thing is that pathological jaundice can arise later also, secondary to sepsis or secondary to hypothyroidism or other factors which we will be discussing. But if a jaundice has occurred before 24 hours of age, it is definitely pathological jaundice. So an elevation of total bilirubin that requires phototherapy, and this elevation which will require phototherapy is decided as per our Bhutani nomograms, which I will be showing in the next slide. So it is basically the rate of rise in total serum bilirubin or transcutaneous bilirubin level of more than 0.2 mg per deciliter per hour. And it could be associated with signs of illness like vomiting, lethargy, poor feeding, excessive weight loss, apnea, tachypnea, or temperature instability. And more importantly, what we need to see is a poor feeding, lethargy. And pathological jaundice usually persists for after 14 days in case of a term infant. Now coming to Bhutani nomogram. So this is the Bhutani nomogram, which basically has where the y-axis shows is plotted for total serum bilirubin, 5, 10, 15 mg per deciliter, and the x-axis shows age in hours. And it has been divided into 4 zones. That is high risk zone, which is beyond the 95th percentile, and which marks neonatal hyperbilirubinemia in the terms of pathological jaundice. Then there is a high intermediate zone, which is between 75th and 95th percentile, low intermediate zone, which is between 40th and 75th percentile, and below the 40th percentile is low risk zone. So so this is basically the measurement of our specific bilirubin in case of neonates, in order to decide whether a neonate requires phototherapy or further management or not. So, for example, if at 12 hours of life, a child's a baby's bilirubin is somewhere around 10 mg per deciliter, then that is well above the 95th percentile, and it is pathological jaundice for that neonate. Now coming to the causes of jaundice. So here we have divided the jaundice based on the time of appearance of jaundice. So appearing within 24 hours of age is going to be pathological jaundice, and most common cause of that is hemolytic disease of newborn, which could either be because of RH incompatibility or ABO incompatibility. In ABO incompatibility, it's mainly when the mother is of O blood group and the baby is of A or B blood group. Whereas in RH, it's when the mother is RH negative and the baby is RH positive. Then it could be because of infections like torch, malaria, or bacterial infections. So these intrauterine infections or any sort of infections is moreover going to lead to a conjugated hyperbilirubinemia. Then we have G6PD deficiency. Other causes, that is between 24 to 72 hours of life, physiological, the most common. After that, it could be sepsis, whereas sepsis also mostly leads to conjugated hyperbilirubinemia. It could be because of polycythemia, that is greater RBC concentration leading to greater RBC destruction and hemoglobin production. It could be because of an intraventricular hemorrhage or increased enterohepatic circulation, or if a baby has got a cephalohematoma or any other hidden hemorrhage. Then after 72 hours age is moreover because of sepsis, cephalohematoma, neonatal hepatitis, and extrahepatic biliary atresia, where both of these, that is neonatal hepatitis and EHBA, are causes of conjugated hyperbilirubinemia. Other than that, it could also be because of breast milk jaundice or metabolic disorders like G6PD. So now coming to breastfeeding jaundice. Breastfeeding jaundice is also known as breastfeeding failure jaundice now, because this occurs due to the failure of adequate breastfeeding in babies. What happens is basically in the first 48 to 72 hours, few mothers may not have adequate lactation, as a result of which the baby is feeding less. Now, when there is less feeding, there will be, as a result, less intestinal motility and less stooling. Less stooling leads to retention of the unconjugated bilirubin and hence the jaundice. So it occurs mainly in exclusively breastfed infants and hence appears at 24 to 48 hours of age, peaks by 5 to 15 days and disappears by third week. It is related basically to inadequate breastfeeding. It does not require any other treatment other than proper and adequate breastfeeding. Once there is proper feeding, there is proper stooling and hence clearance of the jaundice. Now coming to breast milk jaundice. Now this is different. This occurs in about 2 to 2.4% of all the infants, and it begins after the first 3 to 5 postnatal days. It peaks within 2 weeks of age, and if breastfeeding is continued, then it gradually returns to normal levels over 3 to 12 weeks. But if at that particular point we stop breastfeeding for around 48 hours, just 48 hours, then the bilirubin may rise, the bilirubin will fall rapidly. And again, when we start our breastfeeding, the bilirubin may rise by 2 to 4 mg per deciliter, but it will definitely not reach the previous high level. So affected infants may have good weight gain, normal liver function test results, and no evidence of hemolysis. Mechanism of breast milk jaundice is thought to be either associated with Gilbert disease or perhaps a factor in human milk, possibly beta-glucuronidase, which increases the enterohepatic circulation. So this is a quick way, that is risk factors for jaundice. A jaundice which appears within the first 24 hours of life is pathological jaundice. We have to look for a sibling who was jaundiced as neonate. Any sort of unrecognized hemolysis like intraventricular hemorrhage or more locally like a cephalohematoma. Non-optimal sucking or nursing is a warning sign. G6PD deficiency has to be ruled out. We have to rule out infections, cephalohematoma or bruising, and racially it's more common in East Asian or North Indian races. Now coming to the altered physiology, so the gist is that an increased RBC destruction leads to the bilirubin along with albumin into circulation. This unconjugated or indirect bilirubin with the help of ligandin receptor is taken up by the liver, and there it is conjugated by uridine diphosphoglucuronosyl transferase into conjugated bilirubin. Then the soluble bilirubin is taken up by the intestine, where it is converted to stercobilin and excreted in stool, or it is again hydrolyzed and unconjugated and takes part in extrahepatic circulation. Enterohepatic circulation. So now coming to the management and evaluation of infant with hyperbilirubinemia, in which the first and foremost important point is history. So in history, we have to take it in terms of these 3 points. Firstly, the family history. Has there been any other sibling or any other previous family member who had jaundice, or any other sibling who was jaundiced as a neonate, required phototherapy or any further treatment for that jaundice? Has there been any history of continuous or recurrent blood transfusions in the family? Then in pregnancy and delivery history, for pregnancy, we have to check if the mother has had any intrauterine infections, anything leading to torch, or any other infections during pregnancy. And during delivery, has the delivery been conducted uneventfully, or there was instrumentation leading to any sort of cephalohematoma, or anything suggestive of a difficult delivery? Infant history, has the infant been feeding properly? Has there been adequate breastfeeding? Any warning signs? How is the stooling in the child? How frequently is the baby passing stools? And any other history of cephalohematoma or so. Next, coming to physical examination of the baby, here we have to look for lower gestational age and small for gestational age. Now, preterms are more prone to having jaundice. Secondly, small for gestational age or microcephaly. This is pointing more towards intrauterine or torch infections. Is there any extravascular blood like a cephalohematoma or any petechiae, bruising, etc.? Pallor, polycythemia, and also look for hepatosplenomegaly, again to look for torch infections or any other metabolic diseases like Gaucher's disease or any other lipid storage disorders or so. Now coming to the laboratory tests or more specific investigations. So first of all, the mother's blood, RH and antibody screen in order to check for the mother's blood group and hence rule out hemolytic disease of newborn. Also the infant's blood group, RH and DCT are very important to rule out hemolytic disease of newborn. And ABO or mainly RH incompatibility. Then next we look for the peripheral smear for RBC morphology, that is to look for hereditary spherocytosis or and the reticulocyte count, which helps us towards any of the hemolytic anemias. hematocrit because of polycythemia, or it would also indicate towards a hemorrhage. Then identification of specific antibody on the infant's RBCs in order to look for autoimmune disorders, and direct or conjugated bilirubin, if it is a conjugated hyperbilirubinemia or not. And with prolonged jaundice, we test for the liver disease, torch infections, or any congenital infections, sepsis, or if the child is on TPN or so, and other metabolic disorders or metabolic defects, like I've mentioned, lipid storage disorders or glycogen storage disorders, Gaucher's disease, or hypothyroidism and panhypopituitarism to be ruled out. And we definitely need to rule out G6PD deficiency. So now coming to the management of unconjugated hyperbilirubinemia, which is our main focus, because unconjugated hyperbilirubinemia is the most common cause of jaundice in the neonates. So firstly, therapeutic management. The purpose or the rationale is to reduce the level of serum bilirubin and prevent bilirubin toxicity. Prevention of hyperbilirubinemia can be done by early feeds and adequate hydration and ensuring proper stooling. Excuse me, and reduction of bilirubin levels by phototherapy and exchange transfusion. So let us focus on phototherapy now. So phototherapy is the mainstay or main treatment for neonatal jaundice. And now we will look into the mechanisms of bilirubin reduction by phototherapy. There are three primary mechanisms for bilirubin reduction. And the main mechanism is structural isomerization by light, which irreversibly converts bilirubin to lumirubin, which is a more soluble substance, and this can be excreted into bile and urine even without conjugation. And it's an irreversible conversion. So hence structural isomerization is the main mechanism. Then we also have photoisomerization, but this causes a reversible conversion and slow clearance. And last is photooxidation, which is the least important. Now coming to the characteristics of the phototherapy devices, we basically use light emission bulbs or LED devices in the blue-green spectrum, that is 460 to 490 nanometers, which includes the region where bilirubin most strongly absorbs light, that is 460 nanometers. It needs an irradiance of at least 30 microwatts per centimeter square per nanometer. And illumination of maximal body surface area is aimed at. And if given properly, then it is shown to decrease total bilirubin during the first 4 to 6 hours of exposure itself. Now coming to the adverse effects, there are certain adverse effects like insensible water loss. Phototherapy usually leads to 20% of insensible water loss, and therefore as it also upsets the mother-baby interaction and might defect the feeding sometimes. Hence, there could be dehydration, loose stools. It leads to skin rashes, which is very commonly seen after phototherapy. And when a baby with conjugated hyperbilirubinemia is placed in phototherapy, then because of the photo reactions, certain conjugated bilirubin converts into certain photochemicals, which gives a bronze appearance. And therefore, this is known as the bronze baby syndrome. Temperature monitoring is important because there could be hypothermia. And yes, it upsets the mother-baby interaction. So this is the babies under phototherapy. This is our phototherapy machine. In the left side, we can see a small for gestational age baby or a low birth weight baby, whereas this appears like a term baby. Now, phototherapy device, basically the baby has to be kept in the warmer itself. Either you can place the LED devices from two sides, or one device can be put from above and the other device can be placed from below, and this mattress needs to be removed. Now, when we are giving phototherapy, we have to ensure that the baby also gets feeds every 2 hours for a very restricted or very crisp amount of time, 10 to 15 minutes, so that effective phototherapy and effective feeding both can be ensured. Now, every time the baby is placed back in the warmer or below the phototherapy, we have to turn the baby. And maximum exposure, the baby has to be exposed maximally. Only the eyes and genitals have always need to be covered at all times. Eyes have to be covered with a small eye mask, and genitals can also be covered with a thin mask or a small diaper in order to expose all the body parts. We have to keep on monitoring the temperature of the baby to rule out hypothermia, ensure proper feeding, as well as look for stooling of the baby as well. Stooling as well as urine passage, so that, and skin turgor, so that we can ensure that the baby is feeding well and does not have any signs of dehydration. So now coming to exchange transfusion. Exchange transfusion is the second modality in the treatment of neonatal jaundice and is used in much more sinister cases of jaundice where the requirement of treatment is much more immediate and urgent. So the concept of exchange transfusion is to remove bilirubin when intensive phototherapy fails to prevent a rise in bilirubin to potentially toxic levels, or in infants with neurological signs that are suggestive of bilirubin toxicity. These neurological signs we will be discussing in the later slides as well. Now, this is the most effective method and the most sure method of rapid removal of bilirubin. The principle behind is that in cases of isoimmune hemolytic disease, exchange transfusion also removes antibody and sensitized RBCs, which are replaced with donor RBCs lacking the sensitizing antigen also. Now coming to the choice of blood for exchange transfusion. Usually a double volume exchange transfusion is done, which requires 160 to 180 ml per kg. In case of ABO incompatibility, we use O blood type of the same Rh type. So ideally, O cells suspended in AB plasma should be used. But in case of Rh isoimmunization, which is a more common cause requiring exchange transfusion, we use fresh type of O Rh negative blood. It has to be similar to the mother's blood. That is, Rh negative is very important, because again, if we will give Rh positive, it will not lead to any use. So we use O negative irradiated packed RBCs that are suspended in AB plasma and cross-matched against the maternal plasma and cells. Next, we perform it through an umbilical venous catheter using a push-pull technique in aliquots. So around, depending on the weight of the baby, 5 to 20 ml aliquots can be removed and replaced with the donor blood. Now coming to pharmacological therapy, that is the use of IVIG or intravenous immunoglobulin, which has been used in infants with hemolytic disease caused by Rh or ABO incompatibility. It is used when total bilirubin continues to rise in infants receiving intensive phototherapy or is within 2 or 3 mg per deciliter of the threshold recommended for exchange transfusion. Here, the mechanism is that IVIG may act by occupying the Fc receptors or macrophages and therefore decreasing removal of antibody-coated red cells from the circulation. For this, we administer around 0.5 to 1 gram per kg IVIG over 2 hours and repeat the dose in 12 hours if needed. So prognosis depends on early recognition and treatment of hyperbilirubinemia, because that will prevent the severe brain damage. Now coming to bilirubin toxicity. Bilirubin toxicity, we are mainly concerned about the neurological damage that bilirubin can cause. Basically, bilirubin or unconjugated bilirubin can cross the blood-brain barrier. And in cases of acidosis, increased PaCO2 or hypercarbia, or when there is a sick baby or sepsis, in such cases, the blood-brain barrier becomes even prone to the crossing of this unconjugated bilirubin. It becomes even more easier for the bilirubin to cross the blood-brain barrier. And this unconjugated bilirubin has got certain favorite sites in our brain to lodge into. That is mainly basal ganglia, then cochlea, as well, cochlea in the ear, I mean, basal ganglia, cerebellum, and even in certain parts of the white matter. And that leads to bilirubin-induced neurological damage. Now, this neurotoxicity could either be acute bilirubin encephalopathy, which is 3 stages. The first stage is early stage, where the baby presents with lethargy, poor suck, hypotonia, and high-pitched cry. Next is the intermediate stage, where the baby develops opisthotonus and retropolis, eyes are upturned, oculogyric crisis, irritability. And the last stage is the severe stage where there is seizures and coma. And once the last stage has appeared in acute bilirubin encephalopathy, the baby tends to have bilirubin-induced neurological damage and residual damage. So bilirubin-induced neurological damage is when the baby develops palsies related to bilirubin encephalopathy, and also it could be in the form of hearing loss because of cochlear bilirubin toxicity. And finally, coming to kernicterus, the signs of which is the most dreaded and the most deadly complication of bilirubin-induced neurological damage. So signs of kernicterus are as follows, that is chorioathetoid cerebral palsy with neuromotor impairments, sensory neural hearing loss or auditory neuropathy, which is characterized by abnormal BERA. And however, there could be a normal response in otoacoustic emission. There is a limitation of the upward gaze and dental enamel dysplasia. Now, finally, coming to conjugated hyperbilirubinemia, which is a less common cause of neonatal jaundice. This is when a direct or conjugated bilirubin level of more than 1 ml per dl or more than 15% of the total bilirubin level is there. In some books, it's mentioned as more than 20% of the total bilirubin level as well. It may be associated with hepatomegaly, splenomegaly, pale stools, and dark urine. An infant with jaundice more than 2 weeks of age should be evaluated for cholestasis by measuring total and direct bilirubin level. And rapid diagnosis is important because in case of neonatal hepatitis or in case of extrahepatic biliary atresia, where surgery is important and surgery has better prognosis with younger age, rapid diagnosis is extremely important. So the causes of conjugated jaundice are because of idiopathic neonatal hepatitis, obstructive causes like biliary atresia or a choledochal cyst or cholelithiasis in certain cases, infections like intrauterine infections or the torch infections or sepsis, total parenteral nutrition where the intralipid portion causes cholestasis, metabolic causes like galactosemia, alpha-1 antitrypsin deficiency, glycogen and lipid storage disorders, or endocrine causes where hypothyroidism is the most preventable, is a preventable cause and therefore needs to be evaluated, and panhypopituitarism. Thank you very much and take care.